I have been asked to tell you something about continuity of care. So the idea is, the statement is that continuity of care is a key determinant of mental health and quality of life. And I could even also extend it. Maybe it's also a key determinant of prevention. Isn't it that's the issue of this afternoon? So, and if you're okay, I will tell you something about our experience with continuity of care, but I will apply it more concretely to my favorite population, and that is people with intellectual disabilities and mental health problems. Okay, that's the challenge. Good. So you know already that in Belgium there is a committee. It's the highest federal, the most important federal committee for advice for mental health for people, for children and youngsters. So Romina and I are also there in a working group for people with disabilities and mental health, and we can give recommendations to the ministries of mental health, federal, and also to the more regional ministers of welfare, of care for people with disabilities. So it's good to follow the activities. Are all of you knowing that committee? Yes, no, yes, no. Anyway, Romina knows everything of it. Good. So I will talk about two things. We had a working group about continuity of care, and recently we worked together in a working group specifically for children and youngsters with disabilities. And we did some research, we did some action research, some participative research, and I have to tell, it was dramatically. What youngsters told us about their experiences of the mental health care and of the youth care, it was terrible. Okay? So I give you just some individual quotes of these youngsters. Let us listen to them. They are really experienced. They are experts. From birth, always abrupt transitions. From one day to the other, to a foster family, then to a residential group, to another group. Never did I have further contact with previous care providers who I trust and who I liked it. I could not build friendships because I had to change always by group. At age 14, I was placed in a municipality. I had never heard of it. I was completely inaccessible by public transport. So these are some personal experiences of persons themselves. Always barriers, always ruptures. So do you know the concept of continuity of care? I will give you some conceptual information. You know, of course, it's a layered concept. It's not always about organization of care. It's also at the micro level about relation client-caregiver, but then about content and organization of care around the client. And also at the macro niveau, we have to think about continuity of care. Then it's about network, les réseaux, and also about policy and governance. We think that there is a strong correlation between continuity of care and quality of care. Care can only be qualitative if there is a good continuity of care and vice versa. And we have to know that continuity of care is layered, so it's about interaction, of course, relation, client-caregiver. It's also about the coordination, like Romina said, coordination between different care systems. We have education, we have disability care, we have justice, we have mental health care, we have how is it coordinated? It must be integrated. That's the idea. And of course we have transitions. We have it also in our life. but can we make these transitions more gradual? Can we make them predictable? Can we make them smoothly? That's the idea. And of course, if we are thinking about continuity of care, we have always to look in a network perspective, not only about the network of the client themselves, family network, but also the professional network. So like I said already, the continuity of care should not be approached solely from the professional care perspective. First of all, we want to look it about the perspective of the clients themselves, and maybe it's not only about care, it's also about life. It's life, it's not only your care periods, it's the whole life from birth till you die. So maybe we have to look at about more in the idea of life story, of life perspective. That's better than only the care aspect. We know already now from research and also from that guys themselves, the key factor of continuity of care is participation. You don't have to doubt. No continuity of care without participation. The feeling, the sense of control over your own trajectory is the basic for continuity of care. So you have to start there, and not between organizations and information and files and professionality. Okay. So, like I said already, if we have asked the youngsters themselves, it was dramatically, it was disenchanting. They speak us about breaks, ruptures, 10 different institutions and services, unpredictable losses, always more people, always new people. And this care, I thought the coordinator, who was the coordinator who speaks some words, I don't know any word, he said it was not just. This care is not just, is not equal. Maybe it's an attack to the human rights. Maybe it's an attack to the human rights of children and of people with disabilities. Yes? So we know already from scientific research, from clinical practice, and also from federal administration ministry, that continuity of care appears to be one of the spearheads and indicators of current quality of care. So everything you want to do, every project, every new thing, please look first how it is with the continuity of care. That's the idea. And especially when we speak about complex and comorbid target groups, especially there we have a lot of discontinuity, and we have a lot of displacement and stop here, and it's not fitting here, and it's too bad, and it's not for psychiatry, and it's not for youth care, it's not for handicapped care, and always kick out and looking for the next organization. So if you now speak some more theoretically, you can work with the concept of continuity of care. If you understand, it's divided into four factors or 4 aspects of continuity. I will show them here. So these are the four aspects of continuity. Yeah. So it's about relational continuity. First of all, look for the relational continuity. So that is what we call personal continuity. That's about the personal relation between the client and his therapeutic relationship or his caregiver, between a client and one or more care providers. 2 is what we call the management continuity, also important but not as important. And that is coordination and coherence of care. We are looking for flexible and seamless care within and across the boundaries of different care entities that are complementary, and follow each other over some time. And our care must be flexible, responsive, contextual and accessible. Second aspect of continuity of care. Third aspect, information continuity. And that's about sharing of information. Yeah? How can we do it? Because there are a lot of services and institutions involved. So we will think about sharing information from the past and also the personal living circumstances, so that the patient doesn't have to repeat his story for the 500th time. So that's the idea of the information continuity. And the last of the four aspects is experience continuity. Very subjective, and that is what the family, what the patient experiences his care as coordinated and smoothly. He receives help when needed, and he encounters the same people more than other people. So that is the idea. And of course, now we know from research that the last one, the experienced continuity, it's this one we have to focus on it. All the rest is also, but this is really the key determinant. So there we want to measure how our care is organizing. And we developed in the COMS-MEA an instrument, and we call it the continuity reflex. Do you know the continuity reflex already? Pas dans le réseau. That's a pity. But this is an instrument that you can use. You see an x-axis and you see a y-axis. It's a rough matrix. It must be worked out, elaborated. But you see horizontal, then we have the different kinds of continuity, and vertically we have the relevant domains. And now we have participation, accessibility, collaboration, but you can add other things like regionality, or legislation or something like that. So the idea is that you do the exercise on the micro level, on the meso level, and on the macro level. So this is what, with the recommendation, we want to offer, and we want to advise to look, to check the level of your continuity of care by talking, by working with the different stakeholders. So this is the continuity reflex. And now very recently there will be a research of the federal government to guide these things in the networks and also scientifically. Good, continuity reflex. What do I have more? Some suggestions from youngsters. It helps if, as a young person, you can help prepare for the transition yourself. That's not throw on your head, but you can prepare your transition, your next step yourself with the person's that. The youngsters say that mostly it's not the case. You have not control on it. It's just made, and they said next week you go to care. After admission to a child and psychiatry unit, there was a transition to independent living training. Fortunately, someone I trusted accompanied me to the introductory meeting. That are the different things. If you have to make transition, please, is it possible that you ask an educator of 3 years ago that he will join you and share you? Okay? Continuity reflex. Colleagues, continuity of care is not referring. We think, oh, you're doing referring, very good, we're calling, we gave a report, and we make appointments, well done. No, it's not about that. So that's a misunderstanding, that if you're doing very well, next step, that we're doing good care. No, it's also about holding, about keeping, about maintaining, about accompanying lively the transition with the client. But now we have all that stupid systems, I don't know if you have them here in Wallonia, that modules and intensities and escalations and all that. It don't work. That is not continuity of care. That's just organization of exclusion. Something like that. Eh? And of course, what my colleague Romania is very strong in it, transversal, transdiagnostic. There we have to look for it. And of course, specializations are important, but the very good universal things are for every target group. Eh? And maybe we have more in common than in different. So that is the idea. So a transdiagnostic approach and intersectoral cooperation are always standardly needed for continuity of care. So we are asking for co-productions. It's not or for mental health care, or for youth care, or for disability care. The only thing is to do it together. And speak together and come together, and can you do this? And now I will do some more, and then I go some back. So that is the idea in continuity of care and in intersectoral collaboration. It's not about referring. It's not by I do this, I do you this. It's really to do it together. So can I tell you something about my favorite group? I work in 35 years already with that group. Persons with disabilities, intellectual disabilities, and mental health problems. So you know that the prevalence of the comorbidity of this group is very high. It's between 15 and 50%. So you have to know, maybe is continuity of care here very important. Because if you have groups who are characterized by a high vulnerability, by comorbidity, by complexity, by non-specificity, what I mean, you can not always do the same. It's not because they have all a mild intellectual disability that you have to do the same. They are as specific, and the same behavior is totally different than for this person or this person. We could not use the systems that we just heard about psychosis of schizophrenia. And also intensity. So the idea is this group is at risk, not only at risk for exclusion, at risk for what do you call it? Freedom measures. Oui. Ça. So they are at risk. Too high level of medication for people with ID, especially off-label, because of the challenging behavior. No blame for the doctors because it is asked to them, please do something. So that is the idea. What do we know? And we developed a model. I give it to you. The model, you can do what you want. But if you want to think about care, about organization of care, and about projects, maybe you can think about this model. So the idea is that there are always three angles at the same time: the client, the family, and the professional environment. For people with disabilities, more also professional environment. So you have to work, you have to look for them as a major partner who needs as much as attention than the other parties. So every intervention you're looking client, family, professional approach. It's not or but and. That's the idea. And then we proposed. So we propose a care system who is integrated, intersectoral, accessible, and transversal. And then we think you have to think it in terms of a continuum of care. So this is not stepped care, colleagues. No stepped care. It does not work. So one that step and down that step. No. These population is not letting them catching in the system, so it is matched care. So, and there we have the continuum, we have the prevention, the issue of today, and then we have more the care, and then we have more the cure, and then, of course, we have also to develop. So it's not hierarchical, it is a continuum where you jump fluidly, flexible from the one point to the other. So that is the idea. No modulus, no step, no hierarchy, but a continuum. And then it's also the kind of organization of care that we propose is also like that. It is between more ambulant, more mobile, and then residential. So it's not also not or but and. So that is the idea. Can we position the person? Now he has enough with ambulant, mobile teams, but now he has a psychotic, and then we need more, we need residential. So this is the flexible system of schakelen, of switching from one to the other. And very interesting that I will lay to you, this care, must it be specialized or more inclusive? Also, this is a continuum. So this is important, and we have learned if the specialized doors are opening, the inclusive and the general doors are closing. That is my experience for this complex population. We need both. So it is not that everything is possible in the general services, but it's also not that everyone has to go to the specialist or categorical services. So this is a model that you can hold. Well, okay. I have had almost 80 caregivers, but only trusted 2. Yeah. I could not build friendships because I had to change groups so often. It is so difficult to keep meeting and trusting new people. So one professor, Rinaldi, has made some recommendations based on literature for these care systems. But you can find it from her. So, will I take this? Yeah. Continuity of care is a case of transversality. It prevents ruptures, breaks in care trajectories. It focuses on co-productions and intersectoral cooperation. It strengthens the environment of clients, including in that environment also non-mental health partners. Also the barkeeper is also a partner. And sometimes your client is more there, he's drinking too much, but the barkeeper is important for him. It can work preventively regarding admissions, readmissions, and so on. It helps us to arrive at shared care plans and actions. And we think it makes the staff must be flexible. And sometimes the staff is more in the foreground and then in the background. That, for me, that's an interesting idea. So we don't have to be on the table with 15 men and always present, but dependently of the stage, the home worker is more at the foreground. Oh, now more the nurse. More the. So this is the idea of collaboration, foreground and background. So that is what we want to say. Good, let me stop with this. People with intellectual disabilities and mental health problems are not a different kind of people. Okay? So basically they have the same needs. So that's why we have to start in the general services. A good starting point is that you are welcome in generalist mental health services. Sometimes you need some extra expertise, communication tools or what is it, or a specific technical act, we can bring them in the existing general service. So we bring it in with outreach or with mobile teams, but you don't have to, okay. Some cases it is better in the specialized services, but I worked 30 years in specialist services, but it has also a disadvantage. What do you think of a group of 12 youngsters with a mild intellectual disability and challenging behavior? Put them together. What do you think? It will be nice there. So sometimes we organize new problems and new behavior. So I'm specifically I'm playing for heterogeneity. Don't put them always together. That's speciality and everyone knows it. No, it's better. It's better that we have heterogeneity. So I will stop here, Romina. Yeah, the rest you can find it. Oh, maybe there's a new book, there will become a new book in French, about l'autodétermination et le pouvoir d'agir dans le monde du handicap. It's French, it's from French colleagues, and I will leave here the information. Thanks a lot.